name is Bolongaita. I'm a third-year PhD student at BCEPS, where my research focuses on equity and the distribution of health outcomes within populations. Today, I'll be discussing one way in which equity can be incorporated into priority setting, which is through the use of disease severity as a decision-making criteria. In this presentation, we'll be talking about QALYs, or quality adjusted life years, and ICERs, or incremental cost-effectiveness ratios. If you're not familiar with those terms, please check out the resources in the description of this video, and then come back here to this presentation. So first things first, why should we consider disease severity in healthcare priority setting? The idea comes from prioritarianism. Prioritarianism is an ethical framework where benefits to the worst off are given greater weight or importance when making priority setting decisions. In other words, under prioritarianism, health gains matter more when they go to those who are in worst health. This differs from pure utilitarianism, which aims to maximize total health gains without necessarily considering who benefits. So in healthcare, there are quite a few ways to think about who is the worst off. We might think about those facing immediate health crises, like a heart attack or a crushed leg in need of amputation. And while urgency matters, especially in clinical decision-making, that's not the type of worst off that we'll be focusing on today. Today, we're going to be talking about the worst off in terms of disease severity, meaning the conditions that cause the greatest health loss, both in terms of quantity and quality of life. How we define disease severity is one of the key ideas that we'll explore today. In practice, accounting for disease severity means that governments or insurance agencies may fund treatments for severe conditions, even if they're less cost-effective than other treatments for more mild diseases. But importantly, even when severity is considered, it's not the only factor. It must be balanced with other key priority setting criteria like efficiency or cost-effectiveness, overall population health, and sustainability. Today, we'll use a hypothetical disease, Disease X, as our working example. We'll refer to it throughout our discussion. This graph shows the disease profile for an average person with Disease X. On the x-axis, we have length of life, or simply age, and on the y-axis, we have quality of life, measured using quality utility weights, where 0 represents no health or death, and 1 represents perfect health. So let's look at how Disease X affects health over time. Disease onset typically happens at age 20, but the early symptoms are mild. Quality of life drops just slightly by 0.1 for the first 10 years with the disease. From age 30 to age 70, the disease is far more disabling. It reduces quality of life by 0.5. Finally, Disease X leads to an early death at age 70, causing some years of life lost. So what do you think? Is Disease X severe? Determining disease severity based solely on a disease's profile can be challenging. QALYs, or quality adjusted life years, is a metric that can help us assess severity. QALYs take into account not only length of life, but quality of life in terms of morbidity and disability. We'll walk through the QALY calculations together using this graph. We can break the disease progression into 3 phases. The first phase, from 0 to 20, before disease onset. The second phase, from age 20 to 30 with mild symptoms. And then the third phase, from 30 to 70, where more severe symptoms arise. In the first phase, which lasts 20 years, we multiply 20 years, shown on the x-axis, by a utility weight of 1, shown on the y-axis, to get 20 QALYs. In the second phase, which lasts 10 years, we multiply 10 years by a utility weight of 0.9 to get 9 QALYs. And in the third phase, which lasts 40 years, we multiply 40 by a utility weight of 0.5 to get 20 QALYs. Adding all those numbers up, we get 49 QALYs, which means that an average person with Disease X can expect to live 49 quality adjusted life years over their lifetime. Now that we have Disease X in the back of our mind, let's shift to how priority setting works in the United Kingdom. The UK has an agency called the National Institute for Health and Care Excellence, or NICE. NICE provides evidence-based guidance on healthcare, particularly for the National Health Service, which is the UK's publicly funded health system. A key function of NICE is Health Technology Assessment, or HTA, which is used to decide whether new health technologies should be included in the NHS. NICE evaluates three main factors in its HTA decisions: clinical effectiveness, cost effectiveness, and equity considerations. For cost effectiveness, NICE uses incremental cost effectiveness ratios, or ICERs, which show cost per QALY gained to assess value for money. Its baseline ICER threshold is £20,000 to £30,000 per QALY. ICERs within this range are generally considered cost-effective, while ICERs above this range are considered less cost-effective and are therefore less likely to be funded. Okay, so let's turn back to our example of disease X and think about a treatment, which we're going to call treatment A. Treatment A extends life for the average person with disease X by 5 years, and it improves their quality of life by 0.1 after treatment initiation. However, because disease X has mild symptoms for the first 10 years, it's often undiagnosed during this time. On average, patients aren't typically diagnosed and therefore eligible for treatment until age 35, 5 years after the more disabling phase of the disease begins at age 30. On the graph, the blue portion here represents the additional QALYs gained from treatment A. Calculating the area of the blue portion, we can see that treatment A gives us an additional 6.5 QALYs in addition. In total, the average person with disease X on treatment A can expect to live 55.5 QALYs throughout their entire lifetime. Now let's calculate the ICER for treatment A compared to no treatment. As a reminder, the incremental cost effectiveness ratio, or ICER, is calculated by taking the difference in costs between the treatment and the comparator and dividing it by the difference in QALYs. We already know the QALYs. An average person with disease X has 49 QALYs, and an average person with disease X on treatment A has 55.5 QALYs. Now for costs. Treatment A costs £300,000 over a patient's lifetime, and for simplicity, no treatment costs nothing. So we take the cost of treatment A, £300,000, and subtract the cost of no treatment, which is 0, and divide that by the difference in QALYs, 55.5 minus 49. That gives us an ICER of £46,000 approximately per QALY. In other words, treatment A costs an additional £46,000 for each additional QALY gained compared to no treatment. So let's go back to NICE now. Remember that NICE's cost effectiveness threshold ranges from £20,000 to £30,000 per QALY. The ICER for treatment A is £46,000 per QALY, which is well above NICE's threshold. Because of that, treatment A would likely not be recommended for inclusion in the UK's National Health Service, because based on this assessment, treatment A doesn't offer great value for money according to NICE's standard criteria. However, we do know that NICE doesn't just consider cost effectiveness, it also considers equity. One way that it does this is by accounting for disease severity in its decision-making. Disease severity is an equity concern because those in the worst health experience the greatest burden of health inequality. To address this, NICE uses a severity modifier, which gives more weight to QALYs gained from treatments for severe diseases. This, in effect, means that treatments for severe diseases can have a higher cost effectiveness threshold than NICE's standard £20,000 to £30,000 per QALY. To apply the severity modifier, NICE first determines whether a condition qualifies as severe. It does this by assessing two measures, the absolute QALY shortfall and the proportional QALY shortfall. Absolute shortfall measures how much future health a person with the condition loses compared to someone without the condition. It's calculated by subtracting the future QALYs of a person with the condition from the future QALYs of a person without it. So let's calculate the absolute QALY shortfall for disease X. To do this, we first need to know the QALY profile for an average person without the disease so that we can make this comparison. In this graph, you can see that the average person with disease X in pink has 49 lifetime QALYs, compared to the average person without disease X in yellow with 80 lifetime QALYs. Now we can calculate the absolute shortfall. We take the future QALYs for the average person without disease X and subtract the future QALYs for the average person with disease X. Since the absolute shortfall focuses on future QALYs, we only consider the period after treatment initiation at age 35. The future QALYs for the average person with disease X are 17.5, while the future QALYs for the average person without disease X is 45. To calculate the absolute shortfall, we subtract 17.5 from 45, which gives us an absolute QALY shortfall of 27.5. This means that at age 35, when treatment begins, a person with disease X can expect to live 27.5 fewer quality-adjusted life years compared to the average person of the same age without the disease. Now, let's look at this table showing NICE's severity modifier, which helps policymakers decide whether a condition is severe. Based on our calculations, disease X has an absolute shortfall of 27.5 QALYs, which places it in the very severe category on this table. However, we still need to calculate disease X's proportional shortfall. Proportional QALY shortfall refers to the proportion of future health of the average person with the condition compared to the future health of the average person without it. To calculate the proportional shortfall, we take the absolute shortfall and divide it by the future QALYs of the average person without the condition. Here we have the same graph as before, showing the future QALYs after treatment initiation at age 35. For proportional shortfall, we're again taking a future perspective and looking only at the future QALYs for both the average person with disease X and the average person without it. To calculate the proportional shortfall, we take the absolute shortfall, which we already calculated as 45 minus 17.5, which equals 27.5, and we divide that by the future QALYs of the average person without disease X. So we take 27.5 divided by 45 to get a proportional QALY shortfall of 0.61, or 61%. This means that at the time of treatment initiation, or age 35, a person with disease X can expect to have 61% of the future lifetime QALYs of an average person of the same age without the disease. Looking at the NICE table again, we can see that with a proportional shortfall of 0.61, disease X falls into the not severe category. This is quite different than what we found when we used absolute shortfall, which shows that the way that we define severity really matters in practice when making priority setting decisions. Typically, when there's a conflict between severity determinations based on absolute and proportional shortfall, NICE will go with the more severe categorization. So in this case, that means that disease X would be considered very severe, which gives it a QALY weight of 1.7. Now let's adjust our ICER calculation for disease severity using NICE's disease severity modifier. To do this, we multiply the QALYs gained in the denominator by the QALY weight, which based on the table on the last slide is 1.7 for disease X. After adjusting for severity, treatment A costs around £27,000 per additional QALY gained. This ICER falls within NICE's cost-effectiveness threshold of £20,000 to £30,000 per additional QALY, which means that treatment A would be considered as having good value for money after accounting for the severity of the disease that it treats. To summarize, considering disease severity and priority setting is rooted in the principle of prioritarianism, which gives extra weight to those who are worst off. In the context of health priority setting, this often means giving extra consideration to the most severe conditions, those that result in the greatest loss of health, both in terms of the quantity and the quality of life. In practice, this can lead to more funding for treatments of severe conditions, even if those treatments are less cost-effective than treatments for more mild conditions. However, this doesn't mean that all treatments for severe conditions are automatically funded. The disease severity criteria must still be balanced with traditional priority setting criteria, like cost-effectiveness or overall population health. In the United Kingdom, the National Institute for Health and Care Excellence balances disease severity with cost effectiveness by applying QALY weights in its ICER calculations for severe diseases. These weights increase the value of the health benefits for treatments for severe conditions, which in effect raises the cost effectiveness threshold for these diseases. There are various ways to measure disease severity. NICE uses absolute shortfall and proportional shortfall, though other metrics that we didn't have time to discuss today are used in other contexts.